Hello and welcome to this final lecture on your embryological module. In this video we will be exploring teratogens and the complications that may arise from the environmental influences on the developing embryo. After this lecture and after any further necessary study, you should be able to appreciate the commonality of congenital malformations and understand the terms malformation, disruption, deformation, syndrome and association. List and be able to explain the 5 principles of teratology. Be able to classify the causes of congenital malformations, so drugs, infections, radiations, etc. And give specific examples within each group. Describe the incidence and features of fetal alcohol syndrome and understand the mechanisms by which alcohol is believed to cause the features of fetal alcohol syndrome. Appreciate the importance of considering the pregnant patient and minimising the risk of iatrogenic exposure to teratogenic agents in both pregnant and non-pregnant individuals. So what do we mean by teratology or dysmorphology? Well, teratology is the study of congenital malformations. The term comes from the Greek teratos, meaning monster. If you think way back to gametogenesis and gastrulation, we saw this being used in the description of teratomas. Well, strictly speaking, teratology is the study of monster forming. So what we are going to be looking at today are the factors that cause these congenital malformations. These congenital malformations can be structural and visible to the eye. They can be functional. They could be present behaviourally or metabolically. These things we will be exploring throughout the course of this video and arise from some kind of extrinsic factor. When we look at the incidence of congenital malformations, major anomalies occur in about 3% of live-born infants, so this number is quite high. However, even more common is the incidence of minor anomalies, seen in about 15% of live-born infants. One thing that will come up during this lecture is the difference between major and minor anomalies. Minor anomalies may not directly impact the health of the baby, but to a clinician these minor anomalies may invite inquiry into what underlying abnormalities might also be present because of these minor phenotypic presentations. Congenital malformations account for about 25% of infant deaths, demonstrating that they have a hugely significant across Western and indeed worldwide medicine. It is the 5th leading cause of death in people under the age of 65, behind ischemic heart disease and some cancers and suicide. What are the causes of those congenital malformations? Well, if you've watched the first year medical embryology, you will have seen this slide before. 30% are believed to be genetic. This could be from inheritance or through a mutation within the zygote. This will obviously include structural and numerical chromosomal abnormalities, as well as those microdeletions we've seen throughout the module. We could have congenital malformations due to environmental causes, where some kind of extrinsic factor has influenced the developing embryo at a significant point in time. This accounts for about 15% of congenital malformations recorded. Lastly, they could be multifactorial. So 55% of causes of congenital malformations are believed to be the cause by a combination of genetic and environmental influence. And unfortunately, the majority of these multifactorial causes for congenital malformations are unknown. We don't know what or how each genetic and environmental role plays its role to create this, quote, perfect storm of events. So we spoke about those minor and major congenital abnormalities. Regarding those major anomalies, you have probably already studied these in quite a bit of detail, as these major anomalies are going to bring out some significant clinical presentations for you to deal with as clinicians. Things such like atrial or ventricular septal defects. But what about these minor anomalies that are often overlooked? Well, minor anomalies affect 15% of live-born infants, so this number is quite high. To convert this into a more representative figure, that's 3 in every 20 live births. On your obstetrics rotation, this could potentially mean that 1 or 2 live babies born every week in your care will have one of these minor anomalies. These minor anomalies might be isolated, and a lot of the time they can be harmless, but an accumulation of minor anomalies can significantly increase the risk that a major disruption has taken place during development, and therefore it is more likely that there was an underlying major abnormality that you just haven't found yet. For example, if we have one minor abnormality, there is about a 3% chance that there is an underlying major abnormality. For 2 minor anomalies, this figure significantly jumps to 10%. For 3, this is approximately at 20%. It is incredibly important for you to observe as medics, because if you spot a minor abnormality in an infant, you need to bear it in mind that this is potentially just the tip of the iceberg, and you should be questioning whether you need to pursue other lines of inquiry to determine whether there is a major abnormality underlying that just hasn't come to the surface yet. But when did these abnormalities occur? Well, in terms of the developmental pathway, there is a very specific window of sensitivity to the development of anomalies. Firstly, we can see here on the vertical axis is describing the risk associated with a birth defect, and the bottom axis we can see the time period in which the birth defect can be induced. On the time graph, we can see a huge gap in the distribution of time. At this point, it is important to realise that this graph is representing the fertilisation age of the fetus, as used by embryologists, not the menstrual age that you would use in clinical practice. So instead of those equally distributed trimesters, we have developmental ages. 0 to 3 weeks post-fertilisation, which is the pre-embryonic age, where we have rapid cell division, followed by the embryonic age between weeks 3 and 8, sometimes called the organogenesis period, and finally the fetal period until parturition at 38 weeks. So we can determine the time window for development of induced defects happens in a very short window, approximately between 3 and 8 weeks, with the peak of sensitivity featuring around 5 weeks. And that's because this is the window where we are developing those organs. That's not to say that outside this period is safe. If we look to the right of the peak, we can see that the increased risk never intercepts with the time axes. There will always be a risk of congenital abnormality. At the left end of the screen, in that pre-embryonic stage, the fetus is still high risk, but the data for this is so small because the embryo is subject to teratogens at this point, it normally spontaneously aborts. Because this is often before the pregnant person even knows they are pregnant, this information isn't recorded or documented. The term congenital malformation describes types of anomalies, and it is important that we understand what these definitions are. So we have malformations, disruptions, deformations, syndromes, and associations. On this slide, we have an activity to try and get your brain into gear required. Use the headings down the left-hand side of the page to draw a conclusion for the definition of each, and try and find within this soup of text an example for each. Pause the video now before we move on and look at the solution. So to summarise what we have seen, a malformation is disturbed formation of a structure resulting in its complete or partial absence or abnormal configuration. An example of this can be seen in the complete and partial absence of a limb or in atrial or ventricle septal defects. A disruption is the structural alteration due to a destructive process of a structure that has already been formed. So this example can be seen in amniotic bands which cause limb defects. Deformation is the abnormal moulding of part of the fetus by mechanical forces, and this can be seen within the club foot. A syndrome is a group of anomalies that occur together with a common cause. This can be seen in Down syndrome, or one that we're going to take a closer look at today, fetal alcohol syndrome. An association is a non-random occurrence of two or more anomalies together, but the cause is not yet established, and this can be seen in factorial association. We can have look at a couple of examples that we have highlighted. These are images of amniotic bands and the disruption that they can occur on the developing limbs. In amniotic band formation, we have already developed the limb, but there has been a disruption of the developing limb through constriction of the amniotic bands, which formed from the damage of the amnion covering the placenta and then winds itself around the limb and causes compression and reduced blood supply to the distal region. Consequently, we can have poorly developed limbs as a result of disruption to their normal growth pathway. A club foot is an example of a deformity. Club foot can arise from oligohydramnios, essentially a failure to form enough amniotic fluid. This could be from poor development of the kidneys or numerous other reasons. If we don't develop enough amniotic fluid, that amniotic cavity can be compressed and restrict the formation of the fetus, which can lead to a club foot. We can also see in this middle image that a club foot might not be the only presenting deformation as a result of oligohydramnios. The cranium can also be affected, and in this image we can see an example of slanting cranium. When we look at teratology, we need to consider a few principles. These principles are the factors that can cause a congenital defect, and the study of these principles is to determine how easily these factors can cross the placenta and induce a congenital malformation. There are a number of different factors that we need to determine an agent. There are a number of different factors that need to be determined for an agent when determining its capacity to cause a birth defect. Here are those factors that determine the capacity for an agent to cause a defect. Number 1 is genetics. Genetics will determine the ability of the placenta to filter out potential teratogens and stop them from being absorbed by the fetal circulation. How well can the pregnant person break down alcohol? How efficient is the maternal immune system at identifying pathogens in the body and eradicating it before it has time to reach the placenta? Number 2 is timing. When was the embryo or fetus exposed to the potential teratogen? We saw that at weeks 3 to 8 post-fertilization, the embryo is most susceptible to birth defects if exposed during this time. But there are teratogens that, in particular, are efficient at creating a birth defect outside of this window. For instance, with the Zika virus, the developmental window for this teratogen is much wider and much later, between the weeks 7 and 12. Number 3 is the dose and duration. How much of that teratogen was absorbed by the embryo and over how long? We know that the nervous system develops over a long period of time. So high doses over a long period of time can affect the nervous system because the nervous system is more susceptible to teratogens than most of the others. When we look at the effects of teratogen exposure, we will often see that the nervous system is one of the main systems affected because the developmental period is so long. Number 4 is the mechanism of action of that teratogen. How does it work? Does it switch genes on and off? Does it induce or inhibit enzymes? So for instance, in neurofibromatosis and the elephant man, there is a switching off of the tumour suppressor genes. Consequently, there is overwhelming growth, and these tumours appear over the whole body in response to migration and proliferation of the neural crest cells. Once the neural crest cells migrate and proliferate into the structures required, these tumour suppressors will turn off their proliferation. If a mutation has occurred to remove this inhibitory action of the tumour suppressor gene, we have hyperproliferation and excessive growth, as seen in neurofibromatosis. Number 5. And finally, the manifestation of the abnormality. What did it cause? Did it cause some benign tumours? Did it cause a huge congenital abnormality of the heart? How severe are the symptoms? Are they life-threatening or are they just a little inconvenient? These are all the principles of teratology. Essentially, how easy can these agents get to the fetus? When did they get to the fetus? How long was the fetus exposed and with what dose? What did the agent genetically or molecularly do to the fetus and how will this present in phenotype? So how do we classify these agents, these teratogens? What are they? Well, they are infections. Most infections will be prevented from crossing the placenta, but what about the ones that can't be stopped? Radiation. So we have long since discovered that radiation can significantly damage the DNA of cells. But what if we damage one of these during the early totipotent or pluripotent embryonic cell? Heavy metals, and no, not Led Zeppelin, but things like mercury and lead. Collectively, radiation and heavy metals can be grouped as something called physical teratogens. Drugs, sometimes referred to as chemical teratogens, these could be recreational or street drugs, but they could also be prescription or over-the-counter medications too. Pyrexia or hyperthermia. So heat is quite an important teratogen because it can affect the developmental processes, in particular neurulation. It has been shown in animal models that if you increase the core temperature of the pregnant person, it can detrimentally affect neural tube formation. So one thing you should feed forward to your pregnant patients is that they should avoid hot tubs and saunas, etc., as this can lead to an increased risk in developing neural tube disorders. Likewise, pyrexia with infection should be closely monitored and antipyretics such as the pregnancy-safe paracetamol administered to control the temperature. Hormones, again, substances that these cross the placenta. Maternal illness or disease, things like diabetes, obesity or a lack of folic acid. These are all things that can affect the developmental process. Maternal and paternal advanced age, linking right back to our gametogenesis lecture. We see an increased risk in the development of chromosomal aneuploidies in gametes, potentially due to a lifetime exposure of teratogens. So let's have a look at a few in more detail. The first one, infections. There are a number of infectious agents that can cross the placenta. The timing and the dose is going to be particularly important with some of these infections too. Rubella can cause deafness, cataracts and heart defects. Cytomegalovirus, this can lead to calcium deposits in the neural tissue, which in extreme circumstances can cause fetal death or severe neural impairment, as seen with microcephaly and intellectual impairment. We have the herpes simplex virus. Again, this can cause microcephaly, microptia, microphthalmia, the development of the eye. The varicella, again, can cross the placenta and cause limb defects. Toxoplasmosis from cat poop and undercooked meats can cause hydrocephalus, and again, calcium deposits within the brain. So when we are thinking about these infectious agents, we need to consider the principles of teratology. How easily can they cross the placenta? Was the pregnant person's immune system geared up to catch the pathogens before they crossed the placenta? Was the placenta geared up to filter out these pathogens? When was the embryo exposed to these infectious agents? What was the dose and the duration of this exposure? So we can see how teratology can influence your clinical advice, advising pregnant people on their diet. Avoid raw meat, avoid dry cured meats. Avoid changing the cat litter. ensure you are vaccinated against some of these infectious teratogens. Avoid contact with someone who's been exposed to these infectious agents. When talking about these infections, it can become complicated by pyrexia. We know pyrexia can affect the neural tube formation, so it is important that pyrexia is managed as effectively as possible. This can be employing the normal pyrexia protocols like reducing clothing and tepid baths, but it also can be the administration of paracetamol, a drug we know to be safe in pregnancy. However, this leads us nicely on to the next segment and the discussion of medications as teratogens. So, drugs. These can either be medications over the counter or prescription, or we can also include recreational drugs under this umbrella term. So let's have a look at some of these drugs and see if you can match up the medication with the known effect of these drugs in inducing congenital malformations. Pause the video and we will go and look at the results in a second. So we probably know the most about thalidomide. This can cause neural tube defects and congenital heart defects, and most famously, the limb malformations. Note thalidomide was previously prescribed to combat morning sickness, but it was found to induce congenital malformations in those pregnancies. Its mechanism of action is believed to be the inhibition of angiogenesis and the induction of oxidative stress, which will eventually trigger premature cell death. In more developed countries, there is very little concern about the use of thalidomide, but it's not the same in lesser developed countries. Thalidomide is used to treat leprosy, so in places like Brazil, we are still seeing congenital malformations as a result of thalidomide, because of the prescription to treat leprosy, but then the female falls pregnant whilst taking the medication. Antiepileptics, such as phenytoin and valproate, can cause congenital heart defects and cleft palates. Isoretinoin, so a vitamin A analogue, can cause congenital heart defects and severe limb malformations. Antipsychotics. These are suspected with limb and skeletal malformations, central nervous system defects, cleft palate, and CHD, but links are not proven and even disputed by some research. So this is something that has to be taken into account when administering these or prescribing these antipsychotics to patients with chronic mental health disorders. Antidepressants such as SSRIs. We saw this during the process of gastrulation, where these serotonin is particularly important in the lateralization, and therefore a mistake or a mishap with serotonin can trigger or can induce congenital heart defects. Warfarin we have seen develop skeletal abnormalities, and ACE inhibitors are associated with growth retardation and fetal death. Let's move on and have a look at number 3. Cigarette smoke can lead to intrauterine growth retardation, premature birth, and increased risk of orofacial clefts. And this because of the chemicals ingested from the cigarette are able to cross the placenta and be absorbed by the fetus. Even passive smoking has been shown to induce the same congenital defects, which is another reason why smoking in public spaces was banned. Interestingly, one of the questions your early antenatal appointment is whether there are any smokers within the household, and if they are, they, with consent, are referred to the smoking cessation courses offered by the NHS. Number 4, alcohol. So the University of Leeds has published quite a bit surrounding the consumption of alcohol and the risks of congenital abnormalities, and they found not only was alcohol detrimental to fetal development, but also the volume or the concentration of alcohol consumed brought about an increased risk in the severity of those congenital malformations present in the baby. The health guidelines at present are clear. The safest option is not to consume any alcohol at all whilst pregnant. We haven't been able to establish if there is a threshold of alcohol that would be safe, or whether one exists in reality, and we are unlikely to be ever to be able to determine whether there is a safe concentration of alcohol in pregnancy, as there are far too many factors at play. One important thing to recognise is that 50% of pregnancies are unplanned. So the pregnant person that might be carrying on with their life, going out with friends and drinking at weekends. The guidance suggests that any damage inflicted is likely to be minimal, so you might end up counselling a pregnant person who is concerned about the first few weeks of pregnancy and her drinking habits during this time. It is also important to offer reassurance where appropriate and encourage the person drinking to maintain sobriety for the remainder of the pregnancy. It is also important to remember that sudden alcohol withdrawal from a person with alcohol dependency is quite dangerous, so you must follow appropriate procedures in such cases. Now, unfortunately, some pregnant people will struggle to abstain from alcohol, and this can lead to a whole syndrome coming to light. Fetal alcohol syndrome can develop in embryos of such pregnant people. This syndrome can be considered a spectrum, but it is estimated that 0.2 to 1.5 out of every 1,000 live births are affected by fetal alcohol syndrome. But we have some discrepancy in this data, as other studies have revealed it might be as high as 2 to 5% in Western Europe. Some of the phenotypic facial abnormalities can be seen on this image. We could see a smooth philtrum and a thin upper lip, a flattened bridge of the nose. We can also see some epicanthal folds around the eyes. Now, potentially these malformations are only minor, as they largely are just cosmetic and have no functional deficits attached to them. But as we saw earlier in the video, an accumulation of minor anomalies can indicate the risk of having developed a severe anomaly. And in fetal alcohol syndrome, this can be present as severe intellectual disability. So we've mentioned epicanthal folds as an indication of fetal alcohol syndrome, but what are they? Well, these folds are present in the lateral extension of the skin of the nose around the inside corner of the eye. These can often be graded in severity from 1 to 5. On these images on the right, we can see the least severe at the bottom, sliding up to 5 points at the top, where the epicanthal folds almost appear like severe bags under the eyes. Though, as this image demonstrates, the presence of epicanthal folds cannot be used as a diagnostic criterion for FAS, as there are other explanations why these folds have arisen. It is important to know they may be an indication of FAS, but they are not a confirmation of fetal alcohol syndrome. So up to now, all we've really looked at with regards to fetal alcohol syndrome is the phenotypic presentations, but this is not where the story ends. We can have a broad spectrum of defects arising through excessive alcohol consumption whilst pregnant. Once again, I'll make the point about the severity of this spectrum is directly correlated to the concentration of alcohol consumed throughout pregnancy. We can see intrauterine growth retardation, intellectual disability, behavioural problems, heart defects, and brain and CNS defects, such as microcephaly. All of these are representative of those major congenital defects, whilst the last one, the facial abnormalities, are typically minor, as facial anomalies aren't likely to have a functional impact on the infant. But we've talked about the defect, but how does the consumption of alcohol in pregnancy cause this? What are the mechanisms of action? Well, alcohol, or more specifically ethanol, is going to cross the placenta. Once it does this, it accumulates in the amniotic fluid. Remember that the fetus ingests the amniotic fluid by inhalation or swallowing it, digesting it and releasing the metabolites out into the amniotic cavity. Whilst the fetus is performing these actions, it is priming its muscles of respiration, and the kidneys are developing function in order to be able to excrete metabolites. Now, the act of ethanol generates reactive oxygen species and induces oxidative stress. So it is putting undue stress at a cellular level, putting those mitochondria under stress. We also see ethanol having damaging effects on the placenta, so vasoconstriction of some of those vessels, and the outcome of this is going to be well described. If you aren't getting enough nutrients to that fetus, then we're going to see intrauterine growth retardation and things like intellectual disability. Similarly, when we talked about those reactive oxygen species, we could damage the mitochondria, and this can lead to premature cell death. We can also see a disruption of cell-to-cell adhesion, which again can lead to premature cell death. It can also have some epigenetic effects, and that is fetal alcohol syndrome. Now, drugs and alcohol can be termed chemical teratogens, but radiation is a physical teratogen. These images are of that of Hiroshima directly after the bombing, and then in more recent years. Radiation has been directly implicated in congenital abnormalities. It can lead to chromosomal changes and problem in the development of blood, hemopoiesis. In more recent years, we've seen the incidence of congenital abnormalities as a result of Chernobyl nuclear power incident. In even more recent times, there has been an issue in Japan, in a place called Fukushima. Up to now, there has been no increase in the spikes of congenital malformations as a result of the Fukushima disaster, but Japan have been very good at removing the ionising agents from the water. However, Japan has not been able to remove one of these agents, and were planning on releasing this contaminated water back in the sea in 2022. Whether they've done it or not, I don't know, but it will be interesting to see if we end up identifying any more congenital malformations than the current figures over the next few years. So why do we want to consider radiation? Well, we are quite far away from Chernobyl and Japan, and it's unlikely to have that much of an effect on us, right? Well, as healthcare professionals, you are going to have to be particularly vigilant when organising ionising radiation investigations for your patients. Investigations such as X-ray, fluoroscopy and barium studies all use ionising radiation, but CT is the highest on this list. It is important that no one is exposed to radiation unnecessarily, so there are fairly strict protocols in place to ensure that patients and staff aren't overexposed to ionising radiation. It is particularly important for children and also those of childbearing ages, and especially if we are looking at the abdomen and the pelvis. One of the first questions asked by radiographers is whether there is a chance that a patient might be pregnant. In the case of an emergency or when the female is unable to determine the status of pregnancy, a urine pregnancy test may be performed. Staff frequently exposed to radiation, such as those working in the emergency department or within the imaging department, are given lead-lined gowns and monitors to ensure they do not exceed their radiation threshold. So what about hormones? So things like androgenic agents can cause masculinization of the female genitalia. It can cause fusion of some of the labia and cause enlargement of some of the sexual organs like the clitoris. When thinking about the development of the genitals, both male and female genitals are homologous, and what drives their differentiation into male and female genitals is the addition of hormones. So we could see androgenic manipulation of the biological female genitals by the inclusion of these androgenic hormones. Synthetic estrogens can also cause a problem with the female tract. We also see malformation of the uterine tubes later in life, as these can also increase the risk of carcinoma in the cervix and vagina. Environmental estrogens can lead to a decreased sperm counts and increased risk of malformations of the male genitalia. Things like this in the media pop up quite a bit, particularly now as there are more plant-based lifestyles and veganism. A few of the researchers have suggested that an increased intake of soya, which is high in plant estrogens, can have an effect on these male reproductive tract malformations. Cortisone is currently up for debate, as previous research has suggested this can increase the risk of orofacial clefts. So this is something that can be argued is an association with orofacial clefts and not a direct causative factor. Maternal disease, so diabetes and poorly controlled blood sugars. This can lead to a wide variety of defects, including NTDs and heart defects. But we also commonly see macrosomia, or an extremely large baby. Obesity in the pregnant person has been shown to have a variety of malformations associated with it too, including heart defects and omphalocele, as have nutritional deficits been linked with NTDs. As well as maternal, we also have paternal factors. Things such like occupational exposure or environmental exposure to heavy metals and cigarette smoke. There are links with low birth weight and spontaneous abortion and birth defects because of those germ cell mutations. We can also see issues linked with increased paternal age and congenital and chromosomal abnormalities. Particularly when we look at older males, we can see that sometimes contaminants can enter the sperm ejaculant and cause abnormalities with the sperm themselves. So with regards to heavy metals, a few years ago in Japan it was noticed that Japanese women with a high fish diet had increased risk of congenital malformations in pregnancy. Fish like tuna is relatively high in mercury, and mercury has been associated with congenital abnormalities. For reading up on fetal alcohol syndrome, please see this paper. It's probably one of the most recent papers that are available, even though it is back from 2016. This has brought you to the end of the Teratology lecture. I look forward to seeing you for the next one.